just for all the students on the call, just want to say thank you for taking the time this afternoon to sit through a lecture at the end of the day. Hope you're all your day went well today. Was hoping we could all start just by some introductions. We'll keep this really, really light. I'll start. So my name is Jake Ruzovic. I'm an assistant professor here. I did medical school at Johns Hopkins and then residency here at the University of Washington and then fellowship down at the University of Southern California. This is my second year as an attending, so I'm not so distant from you guys that I don't remember what it's like to, be in medical school and the stress of exams and rotations and all of that and the match. So if you could just introduce yourselves, say what year you are, maybe what you're interested in going into, would really appreciate that. So we'll start with Ashka. Nope, looks like frozen. How about
I'm Ashka. Yeah.
Oh, there you go.
I'm Ashka. I'm a fourth year medical student at UW Seattle cohort going into ophthalmology.
Great. Nice to meet you. How about you, Sarah?
Hi, I'm Sarah. I'm also a fourth year from the Seattle cohort at UW, and I'm applying into general surgery tomorrow, actually.
That's right. Match applications are due tomorrow, right? All right. Well, we'll keep this super low key and won't take too much of your time, so you guys can get back to that. Spencer, go ahead.
Hey everybody. I'm Spencer. I'm I guess technically a fourth year med student. I'm doing a research year with the neurosurgery department, and I'll be applying next year.
Great, thank you. How about Taylor?
Hi, I'm also a fourth year at UW, and I'm going into oral and maxillofacial surgery.
Terrific. And Daniel?
Hey, I'm Dan. I'm fourth year and going into family med.
Terrific. And then last but not least, Grace.
Hi guys, sorry, I'm driving. I'm Grace, I'm a fourth year. I'm going into radiation oncology.
All right, we've got a good spread of specialties here, all of which certainly as a neurosurgeon I interact with. And so I hope all of you will take something away from this talk, and please ask questions if there's anything that's unclear. This talk, is just a very general overview of brain tumors. I would not, consider this an in-depth discussion by any means. But I think the main thing just to take away from all of this is in your practice, in your residency, as you go on in your training, if you find a tumor or are concerned about a tumor, certainly just talk to, your senior resident, your attending, a neurosurgeon, an oncologist, just to make sure that they get plugged into the pipeline. So we'll go over just some very general basics. The way we categorize brain tumors, where they are in the brain, how we talk about them. And so a good starting place when you're looking at an MRI or, talking to a patient is to try and figure out, is this tumor intraaxial or extraaxial? So is it in the brain or is it outside the brain? And so when we think of intraaxial tumors, we think of things like gliomas, we think of things like metastases, tumors that are in the parenchyma itself. When we think of extraaxial tumors, we think of things like meningiomas or say hemangiopericytomas that are outside the brain, maybe growing from the dural, covering of the brain and pushing on the brain itself. So that's one way to describe tumors. Second way is just their location. So kind of starting on just very general locations, you can think of supratentorial or infratentorial. So supratentorial would be above the tentorium. And so think of things like in the frontal lobe, in the parietal lobe, in the occipital lobe, in the temporal lobe. Those are all supratentorial tumors. And then tumors that are below the tentorium are ones that are in the cerebellum or, brainstem. And so those are just really helpful ways to think about, where are these tumors arising from? And the next step would be can I identify the symptoms that the patient is presenting with? Is that localized with where this abnormality is? So think of things like, say, a tumor is in the occipital lobe. Do they have visual problems? Do they need to be referred to an ophthalmologist? Say the tumor is on the hearing nerve, or like the vestibulocochlear nerve. Do they need to be referred to for an audiogram before surgery? Is the tumor in the temporal lobe? Is there memory or language affected by it? So always helpful just to remember your very basic neuroanatomy, where these lesions arise from, and see if you can correlate it with what you find on the imaging. So the workup for brain tumors are ones that generally rely on imaging. It's always nice to be able to correlate symptoms to it, but when you start hearing about concerning symptoms, it's best to get an image. I don't think you would ever be faulted by any means for a CT scan or an MRI, especially when you have a clinical concern for a neurological defect or neurologic deficit that you can't otherwise explain. So what does that mean? So say you're like, working in the pediatric population. So high risk population. So children with tumor predisposition syndromes, or if they're complaining of increasing headaches, or, at school, they're seeing a decline in, school abilities or falling off growth curves, then you absolutely want to continue to work that up. And adults, things like nausea, vomiting, headaches that are continually getting worse, headaches that are worse in the morning, like after they're getting up from, being supine for 8 to 12 hours. A seizure. These are all very concerning symptoms that, yes, on their own may not necessarily be 100% sensitive that the patient has a brain tumor. But if you start to hear a constellation of these findings, then your ears certainly want to be perked up. And so once you do get that imaging, it's always best, like I said, to try and correlate it with their symptoms to see if it's something that does match. So what kind of imaging is best? So I will say that your initial test of choice is generally a CT scan. The reason for that is they're cheap, they're easy to obtain, they're fast, and it's a good starting point. Think of it like a 10,000 square foot view or a 10,000 foot view. It kind of shows you that, there's something abnormal that can be better characterized with an MRI. If you wait for an MRI or use MRI as your initial imaging choice, oftentimes patients have to wait like 2 or 3 months to get the MRI. And so that can be fast-tracked if there's an abnormality that's identified on CT. And so that's a really good place to start. I will say skull x-rays, very little utility in our clinical practice of trying to identify tumors. So once you've identified an abnormality, you generally continue to get imaging workup. So say you identify an intraaxial tumor, there's multiple lesions, it looks like a metastasis. You'll want to scan the rest of the body looking for a primary. So I'll kind of open it up to the floor here. Anyone know that, say you have a first-time presentation of a brain metastasis, what is the rate that you never find the primary? Does anyone have a sense for that? How about Daniel?
The rate that you never find the primary, so maybe more like 10%.
Good. How about Taylor? What do you think?
I think it's higher, maybe like 50%.
Yeah, they're kind of more in the ballpark there. It's about 40%. So if there's a brain metastasis, 4 out of 10 people we will never find the primary for, or never see it on body imaging. So you still want to look, because oftentimes, if it's a deep-seated metastasis, tough to get to in the brain, oftentimes say it's a lung tumor or, something else where you can easily biopsy it from somewhere else in the body. That's an opportunity to save the patient a very morbid surgery to get a diagnosis. So the best thing that you guys can do as students, as interns, as residents is alert somebody. Call a neurosurgery consult, call an oncology consult, and we'll absolutely help work, as a team to try and figure out what the next best steps are. So we'll start with brain metastases, and treatment for this has really changed over time. In general, as medical therapy starts to become more advanced with immunotherapy, there are more options than there were say 10 years ago. But in general, these lesions pop up at the junctions between the different lobes. The thought of that being that there's embolic spread at the end of, the termination of these great cerebral vessels. Tend to be at the gray-white junction. And for tumors like lung, melanoma, renal cell, and breast, the median survival following brain mets is only 4 months. So it's not very long. I will say as treatment gets better, so things like safer surgery, radiation, if the patient is going to be a candidate for a targeted therapy or checkpoint inhibitor, that survival gets better. But it's not much better than a year or so, which is good to know. The treatment for it really depends on a number of factors for brain metastases: their location, what they're sensitive to, whether they've had any prior treatment, the functional status of the patient, and the number of metastases in the brain. We'll kind of jump forward to, kind of the more common, or I guess technically less common, but most common primary intrinsic brain tumor, and that's a glioma. And so these are tumors that arise from the glial subtypes of the brain. So think astrocytes and oligodendrocytes. And these are things like astrocytomas, oligodendrogliomas. There's 4 grades of glioma. That's important to know. Grade 1 tumors, are more typically benign. Grade 4 tumors are very, very aggressive. Grade 4 tumors are what we, think of as glioblastoma. Median survival for that is 14 months with maximal treatment, and that includes maximal surgical resection, radiation, and chemotherapy. Without anything, it's about 4 months, and that's after the time of diagnosis. This is kind of a dated grading system, but you can think of grade 1 of tumors, things like pilocytic astrocytomas. Grade 2 is low-grade astrocytomas. Grade 3 is anaplastic astrocytomas. And grade 4 are glioblastomas. So how are these diagnosed? These are all histologic diagnoses as well as molecular diagnoses. It is very, very, very important to know you cannot make a diagnosis based on an MRI. We get that from time to time where patient comes in and said, I've been told I have a glioblastoma by my whatever doctor, got the MRI, and the final pathology shows a grade 2 tumor. And so remember that glioblastoma is a death sentence. There is no survival from glioblastoma. There can be long-term survivors, but there is no cure for it. So when a patient is told that diagnosis, you have glioblastoma, that is a death sentence. And so you do not want to tell them that until you have absolutely tissue, to confirm that diagnosis before you tell them that. So general treatment for astrocytomas really depends on their grade. For grade 1 and 2 tumors, you think of surgery with serial imaging to follow it. For grade 3 and 4 tumors, you think of maximal surgical resection paired with radiation and chemotherapy as the patients are able to tolerate it. hopefully going to be a number of advancements in the field of astrocytomas, especially high-grade gliomas. They like I said, it's a horrible diagnosis to have to give somebody, but even with the hundreds of millions, if not billions of dollars of research, there has not been a randomized controlled trial, at least of a medical therapy, that has shown improved progression-free survival since the early 2000s. So it is an incredibly difficult cancer to treat. Obviously, many people are banking on immunotherapy as kind of the next best thing. But it is something to know that it is an incredibly difficult tumor to treat. And since we do have a future radiation oncologist on the phone here, can you tell us, Grace, what the biggest bang for your buck is with glioblastoma treatment? Surgery, radiation, or chemotherapy?
Radiation, especially
radiation.
brainstem.
Yeah, radiation is the biggest bang for your buck with glioblastoma. So we'll switch gears real quick to meningiomas. Again, extraaxial tumors. These arise from the covering of the brain, thought to arise from the arachnoid cap cells, and they grow. The problem is, they grow, they press on the brain, they press on nerves, and as we all know, the brain is exquisitely sensitive. Then even the smallest tumors and the most delicate locations can cause serious problems. They get their blood supply primarily from meningeal vessels, and the treatment of them, again, is very much dictated by patient age, by the location of the tumor, what the patient actually wants, and any neurologic deficits that they may have. Surgery is kind of the gold standard, but in elderly patients or, lesions that have recurred or already undergone multiple surgeries, gamma knife radiosurgery is a terrific option for these patients. And so always good to remember that. Meningiomas are very common. If you were to pluck 100 people off the street and give them all MRIs, you'd find them in a couple. Most of them are asymptomatic. Most of them can be watched. It's just when they grow to quite a large size that you do get concerned. Subsets of these people, say children that received radiation when they were young, they can develop radiation-induced meningiomas or sarcomas later on in life if they survive that long. So always good to be on the lookout for that. And those tumors tend to be higher grades. So the risk factors tend to be, for whatever reason, meningiomas tend to be more common in women. Probably due to some influence of hormones, whether the hormone receptors of ER and PR are present on these tumors, and rates of atypical meningiomas, so higher grade meningiomas, tend to be more common in men. There are tumor predisposition syndromes, things like NF2 that can predispose you to meningiomas, as well as other types of tumors. So things like bilateral vestibular schwannomas are very common in children with NF2. Radiation-induced tumors can be very common. There are many different subtypes of meningioma. We don't need to go into them. You don't need to understand them. You just need to understand that if you see a big tumor like this on your MRI, you certainly don't want to wait until next week to call a neurosurgeon or an oncologist. Best to alert right away. Oftentimes these tumors can have a hyperostotic component to them. They thicken the bone around there due to tumor invasion of the skull. And oftentimes that bone needs to be removed. So there's 3 grades of meningioma. I think this is helpful to know just when you're seeing follow-up patients. Grade 1 tumors make up the overwhelming majority of these cases. So 90% or so of meningiomas are grade 1. We think of grade 1 tumors as benign. These are all made on a histologic diagnosis. There are criteria to upgrade a tumor from a grade 1 to a grade 2 tumor and from a grade 2 to a grade 3 tumor. You guys do not need to understand that. Just know that as grading gets higher, the aggressive nature of that tumor gets higher as well. So grade 2 tumors make up about 5 to 7% of cases. They tend to recur at higher rates. And grade 3 tumors are very rare, generally about 1% or less. And you can consider these as cancer. This is something that you have to treat very aggressively. So the treatment differs between these. So for grade 1 tumors, we typically think of surgery as curative. Not always the case, but in about 85% of cases, surgery takes care of everything. Grade 2 tumors are a little controversial. Surgery is absolutely recommended. Whether to use upfront adjuvant radiation versus just radiating at the time of recurrence is still debated. And there is a randomized national randomized clinical trial right now asking that exact question. So hopefully we'll know more about that in the coming years. And then finally, grade 3 tumors you want to be very aggressive with, maximal safe surgical resection, as well as upfront radiation. There is no good chemotherapy for these. And so it's kind of a oncologist's best guess when there is inevitable recurrence after surgery and radiation. The rate of resection does matter in terms of the recurrence rates of these tumors. So there was a group that published this in 1957. There is a lot of caveats to this in that the modern WHO grading was not used for this. However, they found that, and one might expect, with increasing rates of resection, you get improved progression-free survival. So if you resect the tumor, the dura that arises from, and the bone over it, your rate of recurrence is about 10% at 10 years. And that goes all the way down to, say you just take out part of the tumor, your rate of progression or recurrence is 40%. So not unexpectedly, the more you take out, the lower rates of progression-free survival is the case. So how about this, Sarah? Does that hold true with gliomas? So things like glioblastoma. How about this? If there's a glioblastoma in the temporal lobe and you do a hemispherectomy, so you take out that entire side of the brain, what does that do for the patient?
My understanding is that they still have poor outcomes regardless of like amount of resection. Is that true?
Exactly right. Yeah. So there has never been a randomized controlled trial to show improved progression-free survival with higher rates of resection. There's retrospective studies that show a benefit to supramaximal resections, and that basically means going beyond the contrast enhancement within the brain. But you can take out half of a person's brain and the tumor will come back on the other side. We'll switch gears into pituitary adenomas. These are my favorite. So pituitary adenomas are predominantly benign tumors of the anterior pituitary gland. They're classified based on their endocrine function. So they can either be functional tumors. So think of things like ACTH secreting tumors causing Cushing's disease, growth hormone secreting tumors causing acromegaly, prolactin secreting tumors causing hyperprolactinemia, or a non-functional tumor. Basically, it's just mass effect. So now modern diagnostics uses pituitary lineage-specific transcription factors. So there's 3 of them: SF1, PIT1, and TPIT. We don't know what those mean yet in terms of their prognostic, nature of them. That's an area of research of mine, but it's basically the more modern diagnostics for them. We call adenomas that are less than a centimeter microadenomas. We call macroadenomas adenomas greater than a centimeter macroadenomas. Pituicytomas and carcinomas are incredibly rare, and you will not see them unless you're a neurosurgeon doing this specifically. So treatment for these really depends in part on the biochemical nature of them, the mass effect. Why don't we go to Daniel? Daniel, can you talk to us a little bit about what symptoms you might be concerned about in a patient with a giant pituitary adenoma?
Yeah, you get some visual changes. So you get that bitemporal hemianopsia.
That's exactly right. Yeah. So we would absolutely be referring to, some of our friends here like Ashka going into ophthalmology to get visual field studies. What other symptoms might we see? Vision is the primary one.
You might also get some nausea, vomiting, like if you're having some compression leading to backup of your CSF.
Absolutely. So hydrocephalus. So if the tumor extends into the third ventricle, causing obstructive hydrocephalus, those are absolutely symptoms you could find. You could also see symptoms of pituitary insufficiency. So, low testosterone in males, that's very, very common. You're unlikely to see symptoms like diabetes insipidus as an upfront symptom. That is primarily seen with lesions of like the pituitary stalk and hypothalamus. So those would be things like craniopharyngiomas, germ cell tumors. Those you'll often see DI, but you don't typically see that with pituitary adenomas. Pituitary apoplexy is a uncommon, in our world common, but in, your guys' world, pretty uncommon syndrome, but it's really good to recognize it. And it's both neurologic and endocrinologic deterioration due to sudden expansion of a mass within the cella. So think of a bleed or a stroke of the pituitary gland or the tumor associated with the gland. So I'm going to go right back to you, Daniel. You talked about vision loss, right? You talked about nausea, vomiting. We talked about pituitary insufficiency. So we're actually going to open up to the whole floor here. So you guys are interns in a very short year, and you're going to be seeing this patient in the emergency room. So can we talk, what tests are we going to order when a patient comes in complaining of headache, nausea, vomiting, decreased vision? We'll start with Dan.
Yeah, I'd probably start with the just CT non-con to start.
Yeah, so I'll just tell you that, there's a giant mass within the cella with blood products in it. So knowing that, Taylor, what else do you want to look for?
I was going to say to check for papilledema and to assess our intracranial pressure.
Good thoughts. Yes, the absolutely patients can present with increased intracranial pressure. So when you're doing your initial exam, absolutely you can look for papilledema. Grace, what else can we do? What else is in our workup?
I might start with like coags and I guess some pituitary labs based on where the tumor's at.
Good. So what pituitary labs would you send?
Like prolactin, growth hormone, FSH, LSH, LH, I mean, that's what's coming to mind.
Good. All right. That's a really good start. With growth hormone, absolutely. You'll want to assess that axis. What's another lab you can send that's not growth hormone, but maybe gives you a sense for that axis?
Sorry, go ahead.
Go ahead. So someone
I think doesn't TSH get influenced on these other hormones?
TSH you do want to check for. Free T4 you absolutely want to check for.
I was going to say, is it like growth hormone or insulin?
So IGF-1 is the test to look for. So think of IGF-1 as like the HbA1c of diabetes. It kind of gives you like a 2 or 3 month like picture of what your growth hormone's doing. Growth hormone is often a send out lab. It takes a week to come back. So, tough to make a snap judgment or a quick judgment based on that lab because it takes so long to come back. So those are all good things. let's go to Ashka. What else are we gonna order or look for?
Maybe a CTA.
Oh, sorry, what?
CTA.
Could look for a CTA. Absolutely. Make sure you're not, you're not being fooled that it's not a vascular lesion. But we're pretty sure it's a pituitary lesion. We've got a CT. What's maybe another imaging modality we can use to MRI to better characterize it, right? So MRI, good. We get a visual field study. So we call your colleagues to do a quick bedside visual field study, since you guys are the best at it. So we do that. And then Sarah, what if you could pick, say the lab's down and your treatment of choice for this is based on one lab and you're only allowed to send one lab, which one are you going to send?
I don't know, actually. I'm trying to think. Yeah, I don't know that I don't know
No
that
problem.
I've answered my answer that.
How about Spencer?
If you're only gonna send one lab,
Yep, you get one. That's it.
I would guess like cortisol.
Not a bad guess. Absolutely, we'd want to know the cortisol. Grace, how about you?
I don't know.
No? Okay.
I want to say like sodium.
Sodium's a good one. We absolutely want to check the sodium. So prolactin. Prolactin is very, very important. The reason for that is that we could treat prolactinomas with medication. So not all pituitary tumors need surgery. If it's a prolactinoma, their prolactin is very high, and say it's a macroadenoma and the prolactin is 1,000, you have your answer. Give them a pill. And if it's something that their prolactin's low, big tumor with visual changes and other issues, surgery. So that's the one lab that you can't forget to send before you sign someone up for surgery. Okay, so with apoplexy, this is absolutely an opportunity for all of you to save a life when you're an intern and look really good doing it. Let's just say patient comes in, blood in the sella, expansile mass causing compression of the optic nerves, and they are going downhill. Their blood pressure is dropping. They're becoming unresponsive. What are you going to do for them? Let's start with Taylor. You get one medication you can give them.
I mean, if our blood pressure is dropping, my first thought is like fluid resuscitation.
You can give fluids and it's still not working.
Page neurosurgery.
You could do that, but you're going to take this away from our talk, and you're never going to forget it. Dan, any idea?
Is it like dexamethasone because you're giving back like their cortisol essentially?
Exactly right. So typically it's hydrocortisone is what we give, a stress dose of hydrocortisone. So just remember 100 milligrams of hydrocortisone in a patient with apoplexy, and you will save their life. Ashka, what happens if you decide to give levothyroxine instead of hydrocortisone?
They'll continue to decompensate.
They will continue to decompensate, likely even faster, and very likely pass away. Very likely die. So remember, hydrocortisone is the medication that you need to give these patients. So generally, if you consult neurosurgery, we'll tell you, draw a stat cortisol. Don't wait for the result. Just give hydrocort. And those patients are in acute adrenal insufficiency, and they would die without an immediate dose of hydrocort. So very, very, very important to remember. It's an opportunity to save a life. It happens every single year, where, a neurosurgery intern We beat this into their heads. They go down to the ER, draw stat cortisol, give them hydrocort, patient, comes back to where they were. So very important. Other symptoms, again, not to worry too much about them, but you can have problems with the nerves within the cavernous sinus. So you can have a cranial nerve 3 palsy. You can have nausea, vomiting, like we talked about. If there's any hypothalamic involvement, you can have issues with hypotension, your temperature dysregulation, respiratory disturbances, or DI. DI being the most common one. But again, I will just, reiterate, hydrocort is the medication to save a life. And you will see this in the emergency room. And, if you were to draw sodium, the sodium would be like 110 or 115. Again, normal is greater than 135. And so the error is just to start repleting sodium or just fluids, treat with hydrocort, and everything will resolve. So just very, very important. This is what it looks like on a CT and an MRI. You can see right here an expansile mass on the coronal here, pressing on the optic chiasm, which would be right up here. My other favorites, vestibular schwannomas. These are benign tumors that grow from the vestibular division of the 8th cranial nerve. Not unexpectedly, they cause hearing loss, tinnitus, trouble with your balance. They are benign tumors. Trouble as they grow. And treatment, deciding on offering surgery is, a very much a complex decision-making process with the patient, with your team, with a radiation oncologist. Oftentimes you can just watch these tumors, but in patients where tumors are large, starting to press on the brainstem, you often are offering surgery. In patients that are older, often gamma knife's a good option. There are many, 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 many different subtypes, many more tumors to discuss. All of these deserve their own plenary session at major conferences. This is just a general overview. But I think the main things to take away from today, one, always look at your imaging. If you order a scan, look at it. So if you're in the ER, if you're on the floors, on a medicine service during your intern year, if you order a scan, your job's not done, you got to look at it, look at the report, and call whatever consulting service you need for it. Not all brain tumors are death sentences. Often, many of them are benign, can be cured with surgery alone. And the very, very important thing is you cannot give a diagnosis until we have a pathologic specimen. Even for the most common pituitary adenomas, vestibular schwannomas, when I talk to patients, I always say this most likely represents a vestibular schwannoma or a pituitary adenoma, but we cannot say for sure until we have tissue in our hand. And that always gives you an opportunity to be surprised, which does happen. And then finally, always be kind of on the lookout for when you can save a life. Pituitary apoplexy is absolutely one of those occasions where you can be the hero. And you just want to remember that the patient's going to present with nausea, vomiting, vision changes, hyponatremia down to 110. And the treatment is hydrocortisone. Draw a stat cortisol and just give the patient hydrocortisone. So very, very important. And I think that's all I have. So I hope this wasn't too much torture for everyone. But please, if you guys have any questions, you're welcome to ask. Otherwise, I'll put my email in the chat. You guys are always welcome to ask. Have seen a few of you rotate through the service, and I hope it's been a good experience for everyone. Obviously, we always welcome feedback. So if there's anything about the rotation, your experience that you think could be made better for future students, I absolutely, welcome the good, the bad, and the ugly. Please let me know. So appreciate you guys staying late to listen, and hopefully you guys learned something. And otherwise, any questions? Okay. Well, hope everyone has a great evening. Good luck on